Good afternoon, dear friends. First of all, I would like to thank AIOC for giving the opportunity to me to express my views on the topo-guided LASIK, which is my approach to the laser vision correction in the borderline corneas. So whenever a patient of refractive surgery walks into your clinic, the various selection criteria are: we can treat by PRK, myopia up to -5 diopter spherical equivalent, and hyperopia of +2.5 diopter or spherical equivalent, and astigmatism can be treated up to 2.5 diopter of the cylinder. And by the LASIK, we can treat up to -8 diopter of myopia, and in hyperopic patients we can treat up to +4 diopters. And in astigmatic patients, we can treat up to 4 diopter cylinder of myopia. What are the various limitations for the laser vision correction? The central corneal thickness should be more than 470 microns for PRK patients, and it should be more than 490 microns for the LASIK patients. The residual stromal thickness should be more than 400 microns for PRK with API on, and should be more than 300 microns for the LASIK patients. And the refractive error should be between -8 diopter spherical up to +4 diopter spherical, and the percentage tissue alteration should be less than 40%. That is the PTA is the total corneal thickness minus the flap thickness and minus the stromal tissue ablated, and the keratometry reading should be between 39 diopters to 48 diopters. So go for an example. It's a female 24 years of age which has a manifest refraction of -2 diopters spherical, -6 diopters spherical with -2 diopter cylinder at 180 degree, and the mean keratometry is 42.71 diopters. The pachymetry is 500 micron, and the flap thickness, I will go for a 90 micron flap. So it's a borderline cornea, but I can do it. How? First of all, which procedure to choose among the LASIK or the PRK? I'll go for the LASIK in this patient. I'll go for choose a thin flap and will do a LASIK or a topo-guided LASIK over PRK. But why not PRK? Because of the post-operative pain and the late visual recovery and the risk of facing higher refractive errors. So should I go for a standard LASIK or topo-guided LASIK? So important things to notice for this: the residual stromal thickness after 90 micron flap should be more than 300 microns, and patient should have a normal topography. And the standard treatment offers, that is the basis of the standard treatment, are based on the keratometry readings, the pachymetry values, and the refractive prescription of the patient. It corrects the sphere and cylindrical component of the refraction only, and it's a good option for the patients having the normal topography. So the TopoLine, that is a topo-guided treatment. This is a new technology which has the unique capabilities that provide surgeons a greater degree of individual customization, and this procedure is redefining the quality of vision, proving that the many patients experience better vision than ever they did with glasses or the contact lenses. So the topo-guided treatment offers us a basket of choices. You can go for a topo-guided LASIK, which corrects the refractive error based on the topography of the cornea and centers the ablation profile on the visual axis for better visual quality and maintains the asphericity of the cornea along with the reduced depth of ablation. And in the topo smoothing procedure, you can do the anterior corneal surface smoothing with or without refractive error correction. So the topo-guided LASIK, the principal elements are the assessment of the topography and centering the ablation on the visual axis. It's a topo-guided platform is provided by Zeiss. It has an Atlas corneal topographer with the CRS master software, and you can use MEL 80 or MEL 90 excimer laser for this. So on the corneal topography, the patient eye is imaged and analyzed using unique elevation points on the cornea. So the topo-guided planner, that is the CRS master, the Atlas data is sent to the CRS master to create a customized ablation profile, which allows the combination of standard and topo-guided treatments. The preview on the CRS master, that is the planning station, you can see a orange cross which represents the pupillary center, and it determines the center of the optical zone and represents the anatomical center of the eye. And green cross, it is on the corneal apex position. It is close to the visual axis and it corresponds to the manifest refraction. The pupil to ring center distance represents the topographically derived angle kappa. In the treatment planning, we import the topography to the CRS master, enter the various treatment parameters, that is the manifest refraction, target refraction, the optical zone, and procedure selection, that is LASIK or PRK, the flap parameters, the treatment mode, and the keratometry readings, which are directly imported from the topographer. So we can, again, the same female, -6 diopter spherical with -2 diopter cylinder, and the pachymetry is 500 micron. You can see the treatment planning on the CRS master between standard versus topo guided. See, the residual stromal thickness after standard treatment is 273 microns, and after topo guided treatment it is a residual stromal thickness 302 microns. The patient which looked impossible for the LASIK surgery, we can go ahead with the LASIK surgery in this patient. So the ablation principle is the ablation starts from the highest point of the irregularity in topo-guided treatments. And the important things to notice for this topo-guided treatment is the perfect topography measurement is a precondition for successful topo-guided laser treatments. And inaccurate or unreliable data from topography will lead to an inaccurate treatment of the patient. And the laser automatically adjusts the laser pulses to match topo-guided treatment. And so else, what can we do with topo-guided treatments? We can treat the corneal irregularities, the optical zone enlargements, and the decentered ablations, the flap complications, the corneal haze, and the irregular astigmatism of the patient. So the various indications for the topography smoothing planning is eyes that cannot be well corrected with glasses or the contact lenses and have irregularities on the corneal surface with inconsistent refraction. And the ablation profile is based on the topography map only. It's a two-step approach. Initially, you create a regular cornea. Later, we correct the refraction with standard treatment, which provides us a higher safety and predictability of the patient. So the customization by the topo-guided planning, it offers us a tissue-saving solution. The clearly reduced depth of the ablation is a major benefit, in particular also for the secondary treatments for these patients. So it is a leap forward. The proven clinical evidence show improvement in uncorrected visual acuity with best corrected visual acuity with the excellent visual acuity outcomes. The clinical results indicate statistically significant improvement in contrast sensitivity and the improved control of lower order aberrations and corrects the topographical irregularities. So to summarize, topo-guided LASIK, it corrects the refractive error based on the topography, ablation on the visual axis for better visual quality, and maintains the asphericity of the cornea with a reduced depth of ablation, and smoothing of anterior corneal surface with or without refractive error correction. And for the secondary treatments for decentered ablations, small optical zones, central islands, flap complication, corneal haze, and the irregular astigmatism. Thank you.
Very good talk. Self-explanatory. In detail you have spoken. Excellent. So how long you tell the patient if you have to do a topo-guided treatment to stop the contact lenses?
Just 1 week before. If the patient is using generally soft contact lenses.
Okay. So anything?
Do you have any financial interest for these?
No financial interest. I'm doing on its own. No financial interest with Zeiss.
Okay.
My talk is not sponsored by Zeiss.
Yeah. Okay. So different, just for the other people, different machines have different platforms to map the corneas. Zeiss has CRS Master.
CRS Master software is there.
Yeah. So for Alcon, they have Topolaser.
The Contura, the Contura,
yeah, Topolaser, what they say.
Yes,
Contura.
but ablation profile, I think different is.
Yeah, so all the machines are good as long as you see your pocket and you understand the how to adjust the parameters, the optical size. He spoke very fast, but he has covered everything in detail, every point.
Thank you.
Yeah. Thank you.
One more question I would like to ask, that these platforms have come recently. Earlier we had different topography machines and different laser machines. So what actual difference in terms of accuracy could you get with these platforms? I mean, earlier we used a different set for laser machines.
Yeah. So earlier, basically, what she says is that we used to do the total aberrations of the eye. Now again,
that was based on the aberrometry.
Aberrometer, total aberrations.
Basically, that aberrometer picks up the total aberration of the eye, and we basically later on there is a change in the lenticular aberrations, and we are treating these lenticular aberrations on the cornea.
Yes.
So when there is a change in the lenticular aberration and the visual quality deteriorates, that's why the concept of the topo-guided LASIK has come.
Yes.
Rather than that the C LASIK, the customized LASIK.
Yes.
Okay. Thank you.
Yes.
Yeah.
Can you give him mic? Can you please give him mic? He's bringing.
He's bringing. So the attention has again gone to the topo-guided treatment instead of the total abrasion sets.
Yeah, definitely, ma'am, because whenever there is change in the lenticular aberration later on in the later life, so the quality of vision will deteriorate in these patients. But the earlier treated with the customized LASIK, when we treated the lenticular aberration in the cornea,
Yes.
why to make it different?
Yeah. No, it will give you the post LASIK, the image quality of the image much more better. And that's why the most of the time patient achieve one mind whatever the patient had the vision before the LASIK with the best correct visual acuity. Most of the you can see the patient read a one line more. Suppose the patient having the 6/9 or something, whatever we explain pre-operatively, you will see the whatever that you see the glasses. So it is found, it is my personal observation, the when it is customized or it is a topo guided, patient will achieve one line more. He can read the 6/6.
Just make a point that we've been doing a lot of this with Schwind, Amaris. It has comes with the Keratron Scout, and it's a very different platform to work with. Very robust. Results have been amazing actually. But it's not that every treatment you have to go towards topo guided treatment. Very important to tailor that out because sometimes we feel that topo guided is great, but it's not that every time you have to go for a topo guided treatment. Sometimes you get better results with the conventional wavefront guided treatments basically. So it's important to understand how your machine interprets the topo. And just another additional point which I also wanted to make was not all topo guided treatments gives you a lesser amount of ablation. It will also depend upon the type of topography that needs to be eliminated. So if you have a peripheral skirt wherein the peripheral skirt is a little more steeper, then those patients will actually require more amount of ablation in that zone. So therefore you will tend to identify some patients where the topo-guided ablation gives you actually more ablation than the conventional. So it's important to just note
there is a
that
difference in the machine. Basically, that is the software which is providing the lesser tissue ablation. In particularly in the CRS master planning, it is there. I'm not planning anything, but it's the machine which tells. Because in Contura, in the Alcon, the ablation is more for the topo-guided treatments.
Exactly.
And out of hardly 10 patients, one patient will need topo-guided treatment if there is any surface irregularity in the cornea.
Great.
If the cornea is regular, that doesn't need any topo-guided treatment. That is overhyped thing. We are treating overhyping that topo-guided treatments.
Perfect point.
Yeah,
Thank
I
you. Thank you.
And there are few wavefront analyzers. We can divide the cornea. We can separate corneal operations from lenticular operations. With those cases works very well.
Thank you, sir.
Especially Schwind that has technology.
Thanks.
Thank you, sir. Thanks for the nice talk.